afternoon, Chairman and Co-Chairman. My name is Tantep Hasuangun, a fourth-year resident on the behalf of Pranangao Hospital. Today, I would like to present how to calculate the risk of instability in displaced distal radius fracture. The distal radius fracture are common injuries, particularly in older adults. Accurate risk assessment for the instability is crucial for optimal treatment and the patient outcome. As you can see from this graph, the incidence is increased with age and the higher in women more than men. We have an existing literature review way back from the 1999. LaFontaine has identified several factors that can predict instability. He showed a strong correlation between the several factors and instability, but this still can't predict instability yet due to the R cannot determine the magnitude of correlation. Then Nesbitt reported odd ratios between the various factors linked to an acceptable result. Note that age over 60 years old is a significant factor in that prediction. 2 years later, McKinney developed a formula to predict the couple malalignment, used the logistic regression analysis. So, how we start to think, this might help us to understand the prediction of the risk of the instability. Our prospective cohort study aimed to calculate the risk of the instability in distal radius fractures using a more comprehensive approach. The inclusion criteria was focused on the patient with closed distal radius fracture with age above 18 years old. The exclusion criteria will exclude those who underwent surgery, who has previous fracture, open fracture, and irreducible one. And sample size was calculated based on the producing methods. As a result, in a sample of 37 patients. Now, the conceptual framework is we include the closed fracture radius. Then we classify and collect the data as risk factors such as age, gender, BMI, dorsal comminution, radial shortening, angulation, ulnar fracture, ulnar variant, and intra-articular involvement, and categorize and collecting this data and follow up the patient to see which patient developed an instability, which we classified as the reduction was lost under the casting or conservation technique. And this is a flowchart to pick at the patient flow and follow-up process in our study. And unacceptable initial results, such as non-reducible fracture, caused the exclusion. The patient with instability dropped out while weekly follow-up. And the stable cases completed study timeline within the 6 weeks of follow-ups. Data analysis. We use the logistic regression analysis to evaluate the relationship between the factor and instability. And univariate analysis assess the risk of each individual factor, and multivariate analysis to conduct and to eliminate the confounding factors. As the result, and this slide, our study included 50 patients here in summary of baseline demographic data, including the percentage and descriptive statistics show the distribution to be fairly normal across the many factors, as well as the radiographic baseline demographic data, but the population was normally distributed. And the outcome, the unstable patient, we see that there are 76% of the patient who fails conservative treatment, and the outcome show that the stable odds ratio and p-value of each factor. We found that the initial radial inclination had a significant and the highest predictive value across all various factors that we collected. We found that it had a sensitivity were about 92.1%, and the specificity were 66.7%, which R squared is equal to 0.53, respectively show a decent accuracy. In discussion, we're using a logistic regression analysis to ensure a reliability of the result. The initial radial inclination is a predominant factor to predict instability. However, the study population is still too small to represent the entire population, and the predictive model or equation needs to be working in the future. Thank you, everyone.